Hello, welcome back to Quick and Dirty Med School. Today we will be going through the brachial plexus. So let's divide it into the supraclavicular part first, and that is where the roots of C5 through 7 branches. Those will make the long thoracodorsal nerve. Like right here, look at all of these roots eventually make this, and the long thoracodorsal nerve will innervate the serratus anterior. So this will go down the rib cage, innervating that muscle that kind of wraps around the kind of like the lateral almost to the towards the like the center of the ribs really. So it will like wrap kind of like in that motion. So the nerves, of course, don't go alone. The vessels accompany them. The dorsal scapular nerve will innervate the rhomboids and the levator, and that comes from the C5. Sorry, the picture is really blurry. I didn't realize this when you blew it up, but just know this is from C5. Down here is T1, but from C5, this is the dorsal scapular nerve, and those will innervate the rhomboids and the levators. And the nerve to the subclavius will also innervate the sternoclavicular joint. So here is the suprascapular nerve. And the suprascapular nerve will go through the notch of the clavicle below the superior scapular ligament, and that ligament will separate it from the artery. So the artery will be above this ligament, and the suprascapular will go below. The suprascapular nerve will innervate the supra and infraspinatus muscle, so this will kind of go around and wrap behind the shoulder to innervate those muscles. The segmental muscular branches will innervate the prevertebral muscles in the dermatomal fashion. Okay, so the infraclavicular part is below the clavicle, and part of it, the medial cord, will go into the olecranon, so it goes all the way down the arm, all the way to the olecranon, into the epicondyle of the ulnar, and then the medial cutaneous nerve will go down the medial forearm all the way down to the wrist. The medial pectoral nerve will innervate the pectoralis minor and the sternoclavicular part of the pectoralis major. And then they arrive from the medial root of the median nerve, and it will go eventually into the ulnar nerve right here. So like continue down to the ulnar nerve. You can trace it. Here's the medial pectoral nerve right here. This is the branch. The lateral will come from this branch right here. And here, this is the infraclavicular area. But and these will run into the arm. And then the ulnar nerve, it pierces the septa and it reaches the medial epicondyle behind the olecranon, so it kind of like wraps behind the almost behind the humerus really. There's no branches in the axilla or in the arm, it's just a straight shot. But once it enters the anterior compartment of the forearm, it will innervate the flexor carpi ulnaris, the medial half of the flexor digitorum, and in the distal third of the forearm, it will innervate the palmar and posterior cutaneous branches. So the palmar cutaneous branch will innervate the skin over the hypothenar eminence, and the posterior branch will innervate the dorsal, the fourth and fifth fingers. Here you go. And the deep palmar branch will innervate the small muscles in the hand, along with the abductor pollicis. So you can see this palmaris brevis, this is the superficial branch, deep motor branch. The cutaneous nerve is superficial, dorsal is going to be superficial. The deep motor branch is not associated with any sensation, it's just a motor nerve. So the lateral cord is the mostly the musculocutaneous nerve, and that innervates the muscles of the anterior compartment and the skin of the lateral forearm. And then the lateral pectoral nerve will innervate, of course, the pectoralis major and minor. The lateral root of the median nerve will pierce the coracobrachialis muscle belly, and it goes like below and under the biceps. The cutaneous branch of it will pierce the fascia and, of course, innervate the skin. So here is the medial cord, here is the lateral cord, and here is the posterior cord. And it's kind of important to know where these segments are. As you can see, these are the roots, the nerves. They will be right in your neck. Trunks, more like right here, near towards the clavicle, and then the cords are in your axilla region, and then the branches will like divide past the axillary region. So you can see here, remember when we were talking about the ulnar nerve, it goes down here, and the ulnar nerve will innervate like this area, the medial cord and nerves, and the divisions will innervate the wrist. This segment of the superior cord will innervate the elbow area, the cubital fossa, and then the dorsal scapular area, C5, will innervate the shoulder. And they all kind of interconnect here before branching off towards this area. So the posterior cord is made from all three divisions. Like all of them play a role in the branches will all like kind of come together in the posterior cord. Radially, the posterior compartment muscles, the skin, and the dorsum are innervated. The axillary nerve will innervate the teres minor, the deltoid, and the skin over the deltoid. The axillary nerve will also pass through the quadrilaterum foramen and curves around the humerus under the deltoid. Here you go. Remember the quadrilaterum foramen? It's one of the triangles. Here it goes through it. Quadrilaterum foramen, just as a reminder, is the border of the teres minor, and then the teres major, the humerus, and that's 3 points, but the roof of the quadrilaterum is going to be the deltoid muscle. See? So there it goes, going through and then innervating everything. So the subscapular nerve will innervate the subscapularis and the teres major, and the thoracodorsal nerve will innervate the latissimus dorsi. The superior lateral cutaneous nerve will innervate the lower half of the deltoid, and the posterior circumflex humeral artery will follow all of these branches. See how they all divide right here. That's why the vessels are called the circumflex artery. So the radial nerve goes down the profunda brachii and the spiral canal into the posterior compartment of the arm, and once in the spiral canal, the extra branches will innervate the skin along with the triceps, and it's all followed by the profunda brachii artery. So it will innervate the posterior cutaneous nerve of the forearm, and it also branches into the inferior lateral cutaneous nerve of the arm, and then a branch of it will innervate the long head of the triceps, and there's going to be another one that innervates the short head of the triceps and the anconeus. So the branches of the radial nerve will go to the brachioradialis and the extensor carpi radialis and part of the brachialis. And then the cubital fossa is where the radial nerve will split into the deep and superficial branches. The deep branch will innervate the extensors and the interosseous muscles, and the superficial radial nerve will innervate the skin over the dorsum and the first 3 fingers right here. So this is like the cutaneous innervation, right? So this is the back of the arm and then it's almost like lateral, because remember, lateral is towards your thumb, medial is your pinky, right? So it goes kind of like inferolateral, and then like to your thumb, and then like the first half of the fingers. The only two fingers that it goes like, you know, and innervate like all the way to the tips is the thumb and the middle finger. All right, so the medial nerve will pass through the pronator teres, and it's made out of the roots of the lateral and medial cords. Like they all come together in one of the cords, and there are no branches in the axilla or the upper arm, similar to the ulnar nerve. The branches of this nerve will innervate the anterior compartment of the forearm. The superficial branches, will innervate the skin of the palm. And then the deep palmar branch will innervate the muscles of the thenar, eminence, and the first two lumbricals. The sensory branches to the palmar skin of the lateral three fingers. Remember, lateral is thumb. And the common palmar digital nerve will split into the proper palmar nerve, which runs adjacent to the bones and the digits. So I'm not sure if you can see it here, but it will run like laterally, so it doesn't go like deep, or it doesn't go like straight down your fingers. It'll go like laterally on the sides of the fingers. Remember when a couple like lectures ago we were talking about a nick in your thumb where your index fingers is quite dangerous because that's where infections can spread. It's also quite painful because that's where the nerves like enter, right, and supply the skin, the fascia. So no symptoms of pain are going to be felt over the thenar eminence in carpal tunnel syndrome because the median nerve is not compressed right there. But here is the branches, the palmar cutaneous nerve, and the digital cutaneous nerve. It goes down here, median nerve, into the hand. Okay, so we go through dermatomes like quite often, but it's important to know different areas of the spinal nerves because the skin is innervated by one specific segmental levels. There's no mixed fibers, as in there's no mix of motor and sensory fibers. But look here. So this is like, you know, C3 through 4, 5 through 6, and then here is the radial, dorsal, antebrachial, cutaneous nerves. There you go. There you go. Lateral antebrachial cutaneous nerve. Here's more of the radial. Radial is right there. There's the palmar, digital palmar right here. These are all innervated by the ulnar. And then here is your medial antebrachial. Okay, so the reflexes are important in the arm because it tests for like C5, 6, and 7 injuries. If there isn't any like dermatomal manifestation, like there's no rash or the weakness is a little bit too widespread, reflexes are really important. So the biceps reflex, you would tap the tendon right at the cubital fossa. You can actually palpate it yourself. You need to kind of like you need to supinate the hand and flex at the elbow, and then right on the medial side near that medial epicondyle, you will feel the biceps tendon. You put your finger there and then tap over your fingers with the hammer so you don't harm the patient. Tap like vigorously, and the bicep will flex and the arm will jerk upwards in a little bit, in a little motion. It's not gonna like, you know, whack you in the face or anything, but it will jerk upwards, and that's how you test the reflex for the biceps. For the triceps, you test, you know, the cranial roots of like 6 and 8. So ask the patient to abduct and also pronate their hand, so their palm is going to face behind them, and you have to hold their arm up, and then you tap in that tricep tendon right behind the olecranon process. You can palpate it yourself. Once again, tap it, and the arm will swing outwards. And then the brachial radialis will test the C5 and 7, and it's a little bit trickier because it is right in this area. So it's near the thumb area. It's hard to palpate, but it's very it's more medially located. But if you tap it right, there's going to be a slight supination movement. This is the only one that you can tap the patient directly. There's no way to transmit the force of the hammer if you tap through your fingers. Otherwise, as the rest, you do tap through your fingers. You don't tap the patient directly. Okay, so part 2 are the injuries involving the brachial plexus. The first one is Herb Duchenne paralysis, or palsy. It is an injury to the superior trunk of the brachial plexus, right here, C5 and C6. It can happen during a fall. So if there's a very if you fall head first and then you turn your head and hit your shoulder, this can cause it. This can also be caused during childbirth if the head is flexed and the child is being pulled out by their head. And it will cause a paralysis of the deltoids and teres minor. But the brachialis is not completely paralyzed, so there is some form of flexion, but it manifests in the arm being stuck in a prone position. There's going to be a wader tip deformity of the wrist. See how it turns in and the hands scoop out. There is some Horner syndrome, the ptosis of an eye, usually on the side of the affected limb, and then there's going to be bird winging of the scapula. That's when the muscles of the scapula doesn't adhere very tightly to the vertebral column and the posterior chest wall. Klumpke's paralysis is another form of brachial plexus injury that involves the excessive upward pull of an arm or during childbirth. This is a T1 injury. So if a child is being pulled out of the vaginal canal by their arm, this can cause this injury. The interosseous muscles are paralyzed along with abductors, and that causes a claw hand deformity, as you can see here. So herbs, the arm will be pronated, and there's going to be the scoop of the wrist, while in Klumpke's, it's going to be the claw hand, and it involves C8 and T1. And if the supraspinatus is affected in a superscapular injury, abduction is going to be affected. And if the intraspinatus branch of the suprascapular nerve is affected, external rotation is affected. As you can see here, here's the supraspinatus, here's the infraspinatus. Sometimes it's painful. The symptoms are kind of variable. Sometimes it's numbness. And then the next thing is that an injury to the long thoracic nerve will affect the ability to raise the arm over the head. And there's going to be paralysis of the serratus anterior, which makes it not possible to rotate the scapula while the arm is raised over the head. So the vertebral border and the inferior angle of the scapula will not be closed, making the winged scapula. Here, this is the normal side. Here's the winged scapula. Look how it doesn't bind very well to the posterior chest wall. Okay, so if the axillary nerve is injured, there's going to be a paralysis of the deltoid and teres minor, and that will affect abduction of the arm, and it will also cause numbness in that area. There's going to be a loss of sensation over the lower half of the deltoid muscle, and this is really characterized by deltoid wasting. As you can see here, look at this man. So right here, his deltoid is nice, prominent, rounded. Here, there's hardly any deltoid at all. Like right here, this is not part of the deltoid. This is actually part of the humerus. This is the joint right here. Here's a better picture. So right here, you can see the slope of the shoulder and the deltoid. His pulse is like, right there. And then right here, that's the humerus. Right here is missing. All the deltoid has been atrophied away. Here you can see it even better. This is all bone. There is hardly any deltoid left. So look here. Look where the axillary nerve is, right? So this can be injured in a fracture if it moves backwards, or backwards and impinges on this part of the nerve, or if the fracture displaces the bone forward, it injures this part of the nerve. And it can also be caused by a dislocation of a shoulder. So the shoulder, remember how there's like a couple different kinds of shoulder dislocations? So if it dislocates anteriorly, it presses on the axillary nerve, but also like all these other nerves too, such as like here the superior cord right here. It might press into the medial cord right here, and the posterior cord right here. That might be pretty terrible. And this will cause like all this to be weakened. And then radial nerve injuries, they're really defined by like wrist drop. And generally they are damaged in the axilla and the spiral groove because a fracture of a humeral shaft right here. It can also be caused by the pressure of the back of the arm on a hard surface. So if it's like extended amount of time and the patient is on their back for a very long amount of time, and there's like something like pressing their arm down on something like hard with an edge, that can damage the nerve. And the damage to the main trunk will paralyze all of the extensors. So if it's like high up here, it will result in a wrist drop. So the deep branch of the radial nerve is damaged and fractures of the proximal end of the radius, or dislocation of the radial head. And if the nerve supply to the supinator and extensor carpi radialis is undamaged, there's no wrist drop. So damages down here, like more towards this region, isn't going to result in a wrist drop, while damages up here towards like the actual like arm region versus the forearm regions, that will more likely result in the wrist drop. There's not going to be any sensory loss because the deep branch is a motor nerve, and generally that is not damaged. But if the superficial branch is damaged, there's going to be numbness in just like the dorsum of the hand right here. Right here, this is just a review of there's going to be loss of extension of the fingers, thumb, and wrist, causing the wrist drop. And then there's numbness over the interosseous muscles right around here. Okay, so good thing, nerves can be repaired. You suture like really the covering of the nerves together, not the nerve itself, and the body will heal the axon. A lot of it is just timing. You have to leave it alone for a long time. Nerves regrow a lot slower than bone, so usually the patients are immobilized with something called like a dynamic splint. Here we go. So the dynamic splint will like kind of compensate for the patient's inability to extend their fingers. So musculocutaneous nerve injuries usually happen high up in the arm, so around the biceps area, and the biceps and coracobrachialis is paralyzed, and the brachialis muscle is weakened. So flexion is affected, but not absent, because the brachialis and the flexors of the forearm will still work. And remember, those were innervated by a different nerve. That's why it's okay. And then, when the forearm is in a prone position, the extensor carpi radialis longus and the brachioradialis muscle will assist in the flexion, and those are innervated, remember, by the ulnar nerve. So flexion is weak, but not absent. But there's going to be sensory loss around the lateral side of the forearm, because here you go, and then here. So the median nerve injuries at the elbow will cause the anterior compartments of the forearm to be paralyzed. The forearm is going to be it's going to remain supine, and the wrist is going to be adducted, like, away from the body. There's not going to be any flexion in the lateral 3 digits, or very weak flexion, depending on how bad the injury is. But there's going to be some thenar atrophy. The thumb cannot go through opposition. Thumb will be laterally rotated and adducted, so kind of like bringing your thumb like back, towards the dorsum of the hand. And it's going to be called like an ape-like appearance. And there's going to be loss of feeling in this area, thumb and all the way to the middle finger. And it's called the hand of benediction, or the Pope's hand. So in a wrist injury, it's really defined as like carpal tunnel syndrome, but the median nerve is usually damaged below the elbow, and it can also be caused by like wrist cuts in suicide attempts. Important to watch out for. And unlike the elbow injury, forearm muscles function, so the fist can be made. Unlike the other injury, or the hand is kind of stuck in the hand of benediction. If the thenar atrophies, there's also like no opposition. Once again, the thumb is abducted and rotated laterally due to the, this should be adducted, sorry, and rotated laterally due to the pull of the extensors. And the first 2 lumbricals are paralyzed. That would be resulting also in a loss of sensation. So the ulnar nerve injuries are generally elbow injuries in the medial epicondyle fracture, because like remember the ulnar nerve runs directly behind it, and it will cause the cubital tunnel syndrome, where the flexor carpi ulnaris and the medial half of the flexor digitorum profundus are paralyzed. And the flexion, if you try to flex the wrist, it will result in just abduction. The adductor pollicis is paralyzed. So once again, there is no thumb adduction, and it results in a positive foment sign. And positive foment sign is, look here, this is a normal hand, and this is the positive sign. So you would ask the patient to like hold onto a slip of paper, and for a normal patient, the negative sign is that the thumb will remain flat holding the piece of paper. But in the positive sign, look, the thumb is flexed, and they will be flexing unintentionally, And look here, look at the first interosseous muscle. Like, look how much has been wasted. Like right here, you see so much has been wasted. How much the lumbricals show right here. Here's another good image. See how the thumb has been like hyperflexed, holding these keys when the thumb should like be laying flat. Right here, once again, numbness and tingling from the ulnar nerve injury. So this is a good review of like where the injuries would occur and how they would manifest cutaneously. So ulnar nerve injury, like the last 2 fingers, palm side and dorsal side. A radial nerve injury, the thumb and like these 2 fingers, but only up to here and on the dorsal side. And then the median nerve would be the thumb all the way to almost the 4th finger, but generally in the palmar side, and the tips of the first and the second indexes. Well, the second and third index, or yes, indexes. Digits. The index in the middle of fingers. Okay, so the wasting of the dorsal interossei will make the lumbricals more prominent, as you saw in that picture before. Like those lumbricals were like almost like permanently flexed. In the severe claw hands, the fingers will assume the position even without movement. It's like permanent. The metaphalangeal joints are going to be hyperextended, while the interphalangeal joints are flexed. And here's a good depiction of the difference between the hand of benediction and the claw hand. So in the in the hand of benediction, the in the distal medial nerve injury, you can't extend the second and third fingers, and in the ulnar nerve injury, you can't extend the fourth and fifth finger. So the hand of benediction cannot extend the fourth and fifth fingers. On the proximal ulnar nerve injury, you can't flex the fourth and fifth finger. And then in the proximal median injury, you can't flex the second and third finger, so you can't form a fist with this one. And for this one, you also aren't able to form a fist. Okay, so the importance of knowing where the trunks, the branches, and the cords are is for axillary or brachial plexus block. The prevertebral fascia continues into the axillary sheath, and you in the axillary approach, you want to insert into the proximal part of the axillary sheath, and remember to test. Pull the plunger a little bit backwards to see if there's any blood in the syringe. You don't want any You do not want any blood in the syringe because that's a danger for embolisms. There's the supraclavicular effect right here, or the cervical approach up here, and these are all used in like arm surgeries or to set like severe breaks. Okay, that's it for now. Thank you for your attention. Remember to review all those branches and those cords, and really memorize what kind of injuries or what kind of symptoms will manifest from an injury in whatever major nerve, right? Okay, so good luck with that.